Hello, everyone. Hello, everyone. I am back with a new podcast. Welcome to the CVICU Notes podcast. My name is thecherylpalmer. I am going to be talking about respiratory basics today. And let's get started. What's the difference between oxygenation versus ventilation? Oxygenation is the addition of oxygen to the system or the human body. Ventilation is an exchange of air between the lungs and atmosphere, so oxygen is absorbed and carbon dioxide is eliminated. What's normal? How do we breathe? Okay, so our respiratory anatomy includes our nasal passages, our oral airway, and the pharynx, larynx, trachea, lungs, bronchus and lungs. And in addition to that, we also have the diaphragm, which is a muscle that enables us to inspire and expire. Adequate oxygenation depends on adequate ventilation, oxygen transfer across the alveolar capillary membrane, hemoglobin, cardiac output, release of oxygen from hemoglobin to the tissue bed, and cellular ability to utilize oxygen. Sufficient delivery to meet cellular demands. Your O2 sat has to be 92% or more. Your PaO2 should be 80 to 100. Adequate ventilation is sufficient movement of air to facilitate appropriate oxygen and carbon dioxide concentrations. Normal tidal volume is 6 to 8 milliliters per kilogram. Normal respiratory rate is 12 to 20 per minute. And normal end tidal CO2 is 35 to 45 millimeters of mercury. It is stimulated by the pH, the PaCO2, the diaphragm, which is the primary muscle of ventilation, dead space with no gas exchange. This could be anatomic and it could be pathologic. And your minute volume is equal to the tidal volume and the respiratory rate, which is liters per minute. Adequate perfusion is sufficient blood movement through the capillary bed past the alveoli, necessary for gas exchange, and the VQ mismatch here in the picture on the right. Anatomic versus pathologic shunts are shown. Let's check for understanding. VQ mismatch is when there's an imbalance between the amount of air getting into the alveoli in the lungs and the amount of blood flow to the capillaries that surround those alveoli. The imbalance can lead to reduced oxygen exchange in the lungs and may result in impaired respiratory function. The V in ventilation, this refers to the process of air getting into the alveoli. When there's inadequate ventilation, it means that not enough air is reaching the alveoli, which can result from conditions like airway blockages or reduced airflow. Perfusion, the Q in the VQ. Perfusion refers to the blood flow to the capillaries surrounding the alveoli. Insufficient perfusion means that not enough blood is flowing through the pulmonary artery capillaries, which can occur due to conditions affecting the heart or blood vessels. Here are some more definitions that you should know about. The PEEP, P-E-E-P, positive end expiratory pressure, that decreases surface tension and prevents atelectasis. And it also extends time for the gas transfer. Lung compliance is the elasticity of the tissues of the lungs. Plateau pressure is the measurement of the elastic properties of the alveoli. Peak inspiratory pressure is the measurement of the elastic properties of the airway. So you may hear these terms being discussed during your rounds with your attendings and your respiratory therapists. And usually, if somebody's intubated, these are some of the things that are evaluated: the PEEP, the lung compliance, the plateau pressure, and the peak inspiratory pressure. Respiratory complications: COPD, emphysema, asthma, and bronchitis. The pathophysiology for these are dynamic hyperinflation, air trapping, low expiratory flow rates, and may have chronic CO2 retention. Signs and symptoms are worsening dyspnea, increased sputum, hypercapnia, and hypoxemia. Treatments include titrating the FiO2 to greater than 60 millimeters of mercury or a SAT greater than 90%. Of course, this will vary depending on your patient's history as well. Bronchodilators, corticosteroids, antibiotics, and mechanical ventilations are other treatments. Pulmonary embolism. The pathophysiology is there is a partial or complete obstruction of the capillary bed. A submassive is less than 50% of the capillary bed. A massive is greater than 50% of the capillary bed. Decreased perfusion resulting in increased PA pressures leading to RV failure and decreased cardiac output and hypotension. Signs and symptoms are dyspnea, tachypnea, tachycardia, chest pain, cough, hemoptysis, respiratory alkalosis, hypoxemia, hypotension, and you could also have a PEA, which is a pulseless electrical activity. Treatments include maintaining the airway, oxygenation, ventilation, fluids, and anticoagulation. So some of the things to prevent that PE would be VTE prevention. You want to mobilize your patient early, apply SCDs, anticoagulation of heparin and Lovenox. Just a note that never minimize what SCDs can do. They're very effective despite what we think, keeping that blood flowing and preventing thrombi formation or thrombus formation in the lower extremities. Pneumonia. The pathophysiology for that is acute inflammation caused by infection resulting in alveolar consolidation, community versus hospital acquired. So there are two types. A diagnosis includes a chest X-ray that may show consolidation or patchy infiltrates. Your sputum culture may show a leukocytosis, and you may have hypoxemia. So for residents or for patients who have pneumonia, you want to, whatever lung is not affected, a lot of times it's both lungs, but whatever lung is affected needs to be up. So like when you're turning them, let's say the right lung is affected, then you want to make sure you keep them on your left side and their back more so on the right side so that you can help expand the lung that's not functioning adequately. Antibiotics, pulmonary hygiene, using the IS, suction, positioning that person 30 degrees or higher, and systemic support, which could be like a ventilator support or ECMO. Prevention, hospital-acquired pneumonia versus ventilator-acquired pneumonia. To prevent these pneumonias, you want to have the head of bed elevated 30 degrees or more. You want to provide oral care. Typically in the ICU, if this person is intubated and ventilated, you want to assess them at least every hour to make sure their airways are clear. and suction them as needed orally or via the inline suction for through the endotracheal tube. You want to make sure you're doing your hand hygiene and tube feeding management. So when your resident or patient is up in the sitting position or upright position over 30 degrees, there's less chance of aspiration to occur. So you want to make sure that they're positioned with the head of bed elevated. When you're repositioning them, you want to make sure that you hold the tube feeding so it's not running at the time that their bed is the head of bed is lower than 30 degrees. And one other tip is that you want to make sure before you lower the patient's head down or put them in a flat position, if they have tube feeding or if they're intubated, you want to make sure you do oral suctioning first because that can be a source of aspiration. Aspiration causes altered level of consciousness when somebody can't, maintain their airway or control their secretions. Depressed cough or gag, feeding tubes, patient positions, which we just talked about, and ileus or gastric distension and secretions. ARDS versus ALI. So ARDS is acute respiratory distress syndrome. ALI is acute lung injury. So for not adult, but acute respiratory distress syndrome, it's an acute onset with a participating event. Person may have bilateral infiltrates. Their PaO2 or FiO2 is less than 200 millimeters of mercury. Their PaOP or PA pressure, occlusion pressure, is less than 18. And this is in non-cardiogenic pulmonary edema. ALI, acute lung injury, has an acute onset with the participating event as well. They are bilateral infiltrates. This time, the difference is the PaO2 and the FiO2 is greater than 200 millimeters of mercury, regardless of whatever PEEP they have. And the PaOP is less than 18. And this is in non-cardiogenic pulmonary edema. Okay. ARDS versus ALI, the severity. ARDS is considered more severe. It represents a more severe form of acute lung injury. To be classified as ARDS, there must be a significant impairment in oxygenation, typically requiring mechanical ventilation, and specific criteria must be met. ALI is considered a less severe form of lung injury. It represents a milder form of respiratory failure. ALI is diagnosed when the criteria for ARDS are not met, but there is still significant lung injury and respiratory distress. Pathophysiology for ARDS and ALI. There's an inflammatory response that's triggered by an underlying injury or condition, such as pneumonia, sepsis, trauma, aspiration of gastric contents, or inhalation of toxic substances. The capillary bed permeability, the inflammatory response leads to increased vascular permeability, causing leakage of the fluid and proteins from the bloodstream into the lung tissue and air spaces. Increased transudate. Due to the release of inflammatory mediators, and the presence of infiltrating immune cells. Massive atelectasis, and comes from alveolar cell damage. Early symptoms are tachycardia, restlessness, mild dyspnea, respiratory alkalosis, crackles. Your chest x-ray may show ground glass, and then PaO2 on room air, usually 60%. or PaO2 of 60. Late signs and symptoms: tachycardia, agitation, extreme dyspnea, respiratory and metabolic acidosis, crackles and wheezes. The chest x-ray might show a whiteout. PaO2 on room air is 30. The treatment. Well, usually if it's, severe, you have to treat them with mechanical ventilation. PEEP should be 10 to 15. Your plateau pressure should be less than 30. And you want to limit your tidal volume to 4 to 6 milliliters per kilogram. And permissive hypercapnia, proning sometimes, and also ECMO. Supportive measures for end organ stabilization. You may have to do fluids, vasopressors, analgesia, sedation, and of course, you want to maintain their nutrition and provide emotional support. There's a 30% mortality rate with multi-system organ failure related to ARDS or ALI, or ALI. Phases of ARDS. Phase 1 is an exudative phase. There's direct insult to the alveoli, that's like with the pneumonia or like gastric acid. Indirect insult to the pulmonary capillary endothelium, pancreatitis, and sepsis. Sepsis is an example. Macrophages sound the alarm, resulting in surface destruction and alveolar flooding. There's a proliferative phase. The macrophages are cleaning up, there's fibrin forming, scaffolding, and then channels are opened up for the protein to escape. So there's leakage. And then you have phase 3, which is fibrotic. There's scar tissue, fibrosis, and remodeling that's occurring, associated with high mortality and prolonged ventilator days. And this depends on the extent of the initial damage. For those of you who are watching the video of this, I've provided the example where you can see the alveoli and the stages of ARDS and ALI. This is the basics. When you are in a surgical environment, just some tips to remember is positioning of the patient. You want them to get mobile as much as possible, as quickly as possible. You want to ensure that they are turned and repositioned. You want to make sure they have the SCDs on. You want to make sure their pain is managed. And always collaborate. If you feel that something doesn't look right, always ask. Never, ever think that your question is not important to ask. So I hope that this was helpful. And I want to give you some resources. So first of all, you can go to my website. It's cherylpalmer.com. There are some articles there that can help you with your critical care career. You can also download a free ebook there. And also, my handle for Instagram is the Cheryl Palmer. Some of the resources that I found helpful, the resource that I found very helpful for respiratory care is the AACN Essentials of Critical Care Nursing, 5th edition. That one just came out last year. You can find this on the AACN website. It is very helpful with you preparing for your CCRN exam as well. And you can also find it on Amazon. So that ends my presentation on respiratory care basics. You can also email me. My email address is Cheryl at cherylpalmer.com. Bye next time.